So good morning, everyone. Thank you for joining our neurosurgery grand rounds today. We are thrilled to be hosting faculty and staff from here at Cornell, Memorial Sloan Kettering, and Robert Wood Johnson today. I hope this is the first of many of our multi-institutional collaborations. We have all been uniquely affected by this pandemic, so it's really great to be able to engage virtually like this. So today it's my pleasure to introduce Dr. Shabbar Danish. He is a professor of neurosurgery and the associate program director at Rutgers Robert Wood Johnson. He fittingly received his undergraduate degree at Rutgers and stayed there to complete his medical school. He then trained in neurosurgery at the University of Pennsylvania, during which time he found the time to complete 2 clinical fellowships in functional neurosurgery and then gamma knife neurosurgery. And he somehow also was able to fit in a research fellowship in bioengineering at Penn, followed by a fellowship in neurophysiology in Spain. He then returned to Robert Wood Johnson, where he joined the faculty in neurosurgery. He became the chief of neurosurgery at the Rutgers Cancer Institute in 2015, the associate program director in 2017, and has most recently been appointed a full professor in the Department of Neurosurgery this month. So congratulations are certainly in order. In addition to his dedication to education and mentorship, he is really a prolific scientist with over 100 peer-reviewed publications. His work in movement disorder, epilepsy, and brain tumors has all been connected by this overarching focus on innovation and minimally invasive techniques. And he is really a leader in the field of laser interstitial thermal therapy, which will be the subject of his talk today. Dr. Danish, we would have, of course, loved to host you in person, but we are delighted to host you virtually. So welcome, and I will turn it over to you.
Okay, great. Can you hear me, Rupa?
Yeah, that's great.
Okay. Wow, thank you for that introduction. So thank you, everybody, for the opportunity to speak this morning. I really appreciate, the time. So I'm going to spend, the morning talking about MR-Guided LITT and sort of try to take us through a little bit of the journey that the field and the technology has taken, what we have struggled with early on, and a little bit about where we are now. Of course, in the time period, hard to go over everything, but hopefully I'll be able to get the message across. So let's see here. Okay. So here are my conflict of interests, and I get consulting honorarium for Medtronic and from Visualase. I'm going to start by trying to define the clinical problem. I think whenever we are dealing with new technologies, it's always important to understand what the problem is. So here's a 55-year-old teacher. She's an anaplastic ependymoma. She's had multiple craniotomies, undergone fracture radiation, radiosurgery. It's a fairly deep tumor, and I'd say, at least in my hands, this is a difficult path to take after all of this. So this isn't a small nodular enhancement. It's grown on a bunch of films. As we know, there's no great systemic therapy for this. Repeat craniotomy in this setting is extremely challenging given its anatomy and deep location in the brain. So these are our unique challenges in neuro-oncology. Okay, now, anytime we see a new technology, I think it takes a very similar sort of approach. We see new technology, we do a first successful case. Our reaction is often, wow, this is amazing, I'm going to use it for everything. And then inevitably what happens is you see our first procedural complication, and then the reaction is, this is terrible, I'm never going to use it again. And so what the goal is, is that every technology or approach has an appropriate case, an appropriate patient, and we want to find that steady state where we offer this technology to the appropriate cases. So laser is an acronym, as many know. It's transmissible across fiber optics, and it can be used anywhere along its wavelength. For patients, for a human body and tissues, there is a wavelength range which is suitable for the human body. This happens to be around 1 micron. And the lasers that are out in use today for this are in that wavelength range. Now, the laser is just a tool to deliver heat. And what this therapy attempts to do is take advantage of the fact that you have time-dependent thermal damage between 45 and 60 degrees Celsius. Above 60, you have instantaneous death, and below somewhere around 43, you give the tissue a slight fever. So it's in this time-dependent thermal damage range that the technology has attempted to create some control for the delivery of heat to then create cell and tissue damage. Now, MR technology also had to change. So as I'm going to get into, this idea of creating burns in the brain is not new by any means. But the challenge was that the imaging technology also had to catch up. So the transition and the understanding that we can use proton resonance frequency and understand that there's a linear relationship between this and the imaging, and we can then acquire these images every couple of seconds rather than every couple of minutes, really change the ability for us to re-explore this technology in the brain. So you take an MR and then you convert it into thermal imaging, and then the next step was the ability to calculate real-time thermal damage. Now, that being said, I'll take a moment to say that most of these images are from the Visualase system. There are 2 FDA-approved systems out there. There's a NeuroBlade system. I'll talk briefly about it. Probably about 90% of the experience here has been with Visualase, with some of this being done with NeuroBlade, and I'll talk about that too. So, but the concepts I think are very similar. So, both systems use the Arrhenius model to estimate thermal damage, and the only reason I bring this slide up is so that we as users understand that even all these systems have limitations, and we have to understand those limitations so that we can take patients safely through these procedures. So the idea of lasers and using image guidance for laser therapy has been around for a long time, but over the course of 20 years, a whole bunch of things have changed. So we have a better understanding of lasers. We have 2 FDA-approved systems in the United States. Cooling catheter designs have changed. That has narrowed our transition zones. Real-time MR has changed. So I think these advances have allowed us to re-explore this in neurosurgery because the tissue there is so much more critical than, say, an organ like the liver, where this is, also used, but you have a lot more flexibility in creating thermal damage. And what we need to accomplish as, surgeons, physicians, et cetera, is also an old definition. This is from 1960, and the idea here is that if you're going to create a lesion, you have to understand you have to have control over the size, you have to control over the location, and you have to understand where this lesion is going to occur. And this is true whether you're using RF, whether you're using laser therapy, whether you're using cryo, whatever technique you're going to use, and nowadays even ultrasound. So I think the needs for the technology are the same. So as I said, we have 2 FDA-approved systems. They have their own differences, and I think the details of what those differences are not really important in the setting of this lecture. It's just that there are 2 out there and that they have differences. Ultimately, I think that when we talk about who's the right patient, what's the right disease, what's the right situation, those conversations are very similar regardless of technology you're using. Now, one thing I like to do is, I like to educate myself a little bit about the places I'm talking about. So there are things about Cornell that I even learned during the course of putting this talk together. So maybe you guys will learn something too. So here is an image from what's called Dragon Day. Now I know you guys are in the city, but this occurs in Ithaca every year. This is a 100-year-old tradition that occurs at Cornell. It's the only place in the country it happens, where first-year architecture students compete with first-year engineering students. So they build this massive dragon, and then the engineering students build this massive phoenix. They parade through the campus. They meet in the center of campus. They have I guess, somewhat of a fake battle. And then after putting months of energy into creating these structures, this is what I found most interesting, is that they just burn it all down. So first time in 100 years that this tradition has been canceled at Cornell. So hopefully you guys, if you guys haven't seen it, you'll take a trip up next year. All right, so let's move on, okay? So in neurosurgery, okay, I think you broadly divide this into neuro-oncology and epilepsy. And these are the 2 broad categories in neurosurgical diseases that we see this. Now, much of what I'm going to talk about today is neuro-oncology, just because we don't have the time to talk in the end. And this is how I divide these categories. I think over the course of the last 10 years, we've seen some of these make a lot of progress and some of these not make, as much progress as we would like to see. Now, when I said, when it comes to ablation for brain tumors, this is not a new idea. This is, the systems are newly FDA approved. But, we saw the first publications in the mid 80s and the early 90s. So if we think about this, this has been around for almost 30 years. So such as the course of, medicine, where it takes sometimes half a century for us to feel like something has enough data and an attraction for us to feel like we can, call it commonplace. So the Visualase system was FDA approved in 2008. And this came after a study that was done in France, done on about 6 patients on recurrent metastatic tumors. So this is what the conclusions or discussion that Alex Carpentier had after his first 6 patients. And you have to see growth on 2 consecutive scans. You probably are limited to about 3 centimeters. Radiation necrosis was not possible, to treat with this technology. He did all of these with a Lexel frame. And around the same time, about a year or 2 after that, we saw the first in human publication for the NeuroBlade system. So both these systems actually came out at very similar times. This was published in early 2013. It's a different wavelength, 10 patients, much bigger tumors. So seeing a max of 20 cc's, whereas in the Visualase system, the first publication saw a maximum of about 8 or 9 cc's. And so hence started this culture of difference between the 2 systems. It started with very early publications. Maybe NeuroBlade is better for bigger tumors. Maybe Visualase is not so good for bigger tumors. Maybe it's good for smaller tumors. And then what happens is, we start to see early reports at our national meetings. And the first reports we saw at our national meetings really with the Visualase system in this country were all in epilepsy, epileptogenic foci, the first study for medial temporal lobe epilepsy. And it got a lot of early enthusiasm. So by 2014, we had, NeuroBlade had grown its user base in the neuro-oncology world, whereas Visualase had actually grown its user base in the epilepsy world for some of these early reasons. Now, when I look purely at Visualase data, what we saw was that in 2014, a couple of years after it started, majority of what was done, or actually it was fairly even, a little bit more epilepsy, a little bit less oncology. And what happens, as the years go on, even though we have an expansion of a user base in this country, is that divide gets deeper. So why does this divide get deeper? And what we see is actually the NeuroBlade numbers are exactly the opposite. And so there's a lot of reasons for why these 2 technologies, although both are used for both, broad disease categories, why they take different paths, I think is very interesting. And one of the stark differences, I think, in the 2 technologies is in this time period, this 2018, 2019 time period, Visualase had a lot of pressure to sell. And the board felt that the only way it was going to sell was by appealing to the epilepsy community. And ultimately, that's the path that they took. And it's sold to Medtronic, whereas NeuroBlade remained a small private company and can, hence remain nimble and do sort of what it wants. Now, from a pure science perspective, and so this is where I think some of this division has come. Now, in early on, we saw early publication for recurrent metastatic tumors. By 2014, we started to see first small publications for epileptic foci. We see multiple, case series and a lot of enthusiasm for Visualase in the epilepsy world and for NeuroBlade in the tumor world, based on what I discussed. But we still had some very basic questions. We're a couple of years into this technology. Although it's 20 years old, we're still somewhat asking similar questions. Who's the right patient, and what are the right pathologies in order to get this, understand, can we use this in neurosurgery? And then we had some very basic technical questions that what's the right size and location, what's the right kind of image registration to use, how do you actually get the laser into the right spot, what are the acceptable levels of inaccuracy, and then all the variables in laser therapy that were still somewhat unknown in how they affect target ablation and ultimately clinical outcomes. So one of the things in any procedure, especially stereotactic procedures, you have to get the laser in the right spot. Here you see a deep tumor, the laser's threading it right through the center. You see a larger tumor here, a little bit more superficial in the corona, and you see the laser skiving the back end of it. And the challenge is that if you don't get the laser in the right spot, the procedure is going to be suboptimal. And I've seen this over and over again where we like to place blame on the technology when, what we really need to do is pay very careful attention to our technique. I think it is true for any procedure that we do. So, as was the case, we started in what we thought was the easier way to do this. We looked at facial registration, we looked at scalp registration, we looked at skull, registration, and there's no surprises here that if you register and use the skull as your basis registration, we had no aborted cases and the accuracy rate was much higher. And part of this for me personally is that I have always done this framelessly. I found that the frameless approach is extremely flexible, especially in the world of neuro-oncology. These targets come in different sizes and shapes and locations, and you have a lot of flexibility in terms of trajectory planning. But 10 years ago, when this started, you really had one or two ways to do this. You had pre-op MRI. You then used a frame, or you did this framelessly. You went to an MRI in order to do this procedure. And such as the case, as the technique involves, this is what it looks like 10 years later. Now you can use frames. You can do this framelessly. You have a whole host of robots you can use. You can use pre-op CT, intra-op CT. You can use all sorts of registration methods. And if you want to avoid all of that, if you have the ClearPoint system, you can just go down to the MRI and you can do this. So there are now, 9 or 10 years later, there are a lot of different ways. And what I tell, what we talk about is that ultimately, I don't think the method really matters as long as you are comfortable with your stereotaxis. And I think for open surgeons to become comfortable with this, you really have to take some time in order to understand and get comfortable with the stereotactic technique, because it's not a natural transition. So going back to this, this happened to be one of our very early cases. And I'd say that when we started this, we started with scalp fiducials. We did this at 12 watts. And I openly admit that I think that we got lucky. Because if I were to do this case 10 years later, I never would have done it with scalp fiducials. I would have used bone fiducials. My accuracy would have been much better, even though in this case it ended up being fine. And I would have used much lower power for reasons that I'll talk about later in this lecture. So what we learned over the years is that scalp registration really does not provide adequate accuracy. And we'll talk about what higher power does. But in this particular case, we did better than palliate. This patient now is 8 or 9 years out, has not had recurrence in that same location, in a situation that was fairly challenging, where we felt like we did not have good options, okay? So let's look at another case here. And so here's an 80-year-old. She has headaches, and she comes to the office and says, I heard that you have a laser, and you can eliminate my headaches by getting rid of this getting rid of this small tumor without opening my head. So what do you do in a situation like this? And of course, do you offer the procedure? We often get, side bended by variables. So before we talk about probably what is the most important issue, which is patient selection, let's talk about the correct trajectory. Probably this is the correct trajectory, but at that time we didn't really have an understanding of how you can put these things through the sinuses. So we say, okay, well, let's come in like this. This is where the laser ends up. So now we're in a difficult situation. We have a patient, you feel somewhat committed, to the procedure. You're very anterior in the frontal lobe, and the laser ends up being posterior to your target. You probably can ablate this, but you have an opportunity to pull the laser out. The laser gets turned on. It's a small target, should be easy to ablate. So it does get partially ablated, but along the way, you end up ablating a lot of the frontal lobe. So here, I think, are some of the lessons learned is, one, this is not the correct patient. It was not the correct target or the correct trajectory. And I think, the conversation here is the patient ultimately did fine. But, in this scenario, that doesn't necessarily make it okay. I think that the conversations have changed over the last decade from, can we do it to should we do it? And I'm going to go through some more examples that have brought us, to that place. Okay, so let's give you guys another Cornell fact. All right, so 20 years ago, all right, this is a very famous, I think, spire in the middle of Cornell campus. So somehow somebody got a 60-pound pumpkin at the top. It was done overnight. It's 170 feet off the ground. And this remains one of the major mysteries at Cornell, that no one understands how this pumpkin got to the top of the spire. And every year there's a gathering at this monument in Cornell for a discussion group to try to hypothesize and throw out reasons for how this may have occurred. It has never occurred since. So I think that if, for those of you guys who are at Cornell, if you go there, you might learn a lot about how to get a pumpkin on the top of a building. All right, let's go on to this, all right? 67-year-old presents with headaches and mild gait difficulty. So enhancing nodule and associated cysts, not a difficult operation in terms of, and very standard approach. So should laser therapy be offered in this scenario? I think when you take a look at this, you say, well, probably not, but maybe there's an opportunity here. So this laser goes in, and the challenge in this required 3 ablations, okay? And one of the challenges here is that this laser ended up being at maximum power. And one of the challenges was that despite maximum power, we failed to get thermal energy to spread through this very acceptable size. And again, I'm going to bypass what is, the first question is this the right patient? But the idea here is that we don't have a real understanding of the power relationship to tissue before we start the procedure. And then this next question, that are cysts a contraindication to using laser therapy? And I'm going to get to that also. So along this line of understanding how this lasers work, okay, I'm going to let this run for a couple of minutes, because I think one of the things that over time we've come to understand is that the enhancing boundary for these targets ends up being a thermal insulator. So as you see on the right, you see a somewhat of a funny shape. Now this is a diode laser. It emits a symmetrical burn. Now this is different from the neuroblade laser. In the neuroblade laser, you have a couple different options, and you have what's called a side-firing laser for funny shaped tumors, with this idea that you can get eccentric burns, and there's a whole host of data for whether that can be accomplished or not. So as you see here, and you watch the thermal energy sort of distribute, and you see the damage estimate come out, you see that even though it's a symmetric symmetric light, you see that it can form actually a funny shape. And there are some things and some anatomic boundaries that the thermal energy will respect. For example, you will not burn through the falls. You will not actually burn through large vessels in the brain. So you can get this through, to sit, fairly close to large vessels, and see the burn actually conform to around those structures without burning through them. Okay, so you can get funny shapes, but the problem is that we can't predict this ahead of time. That's one of the major challenges that exists even after a decade of this procedure being around. Now, understanding the relationship of power to ablation, we can probably take this back to early publications. This is the first publication, and you saw that there was a 50% partial ablation rate. So why did you get partial ablation versus complete ablation? So if you look into the, just broadly look at this, you see that all the complete ablations occurred at maximum power. So if you use lower power, there was a higher risk of a subtotal ablation. Now, that we have seen be corroborated, okay, that that power does matter in these procedures, that if you use higher power, it will lead to larger ablations and quicker ablations. But so let's look back at another case like this. So we start a first ablation here. It's at 80%. The ablation looks good. The thermal energy looks good, but you just don't get enough of this tumor ablated. So say, okay, well, what is our plan B in this system? Really, the only thing that you can do here is turn it up. So you see a second ablation come at 85%, looks good, but still not quite enough. And then we say, okay, well, let's go higher. Let's go to 90%. Let's see if we can push the boundaries of this. And you'll see here in a moment here, that you'll see it's at 13.5 watts here. And you see that you see heterogeneity in that area of red. And that black spot in the middle of the red is an intratumoral hemorrhage. And so when we push the power, the chance of getting signal heterogeneities is much larger. So you get signal dropout during the procedure. This leads to signal dropout during the thermal damage estimate. And in that scenario, what ends up happening is you end up doing somewhat of a blind ablation. The signal, when the signal drops out and you cannot predict how the thermal energy is distributing through the tissue. Now, if you're in the top of the right frontal lobe, this may be tolerable, but in most places in the brain, this is not. And so our gold standard actually is MR assessment. So we found that, okay, so higher power does not have a linear relationship to the development of signal heterogeneity. But if you use higher power, the chance that you are going to get signal aberrations that lead to not only heterogeneities, but I'll talk about the effect it has on MR, will also increase. And so what we want, our goal, we want to be able to calculate our ablation volume. In the current moment, our gold standard is using MR. When you start to get these signal dropouts, you then take the accuracy of the thermal damage estimate. And this is in fact true for both systems. And the correlation that it has to MR starts to change. And we see that the larger ablation that you're trying to do, the more that discrepancy increases. And so once you have signal dropouts and you have heterogeneity in your thermal damage estimate, what you think you're ablating actually may not be true. And it's non-systematic, meaning it's random. You may be under-ablating or over-ablating. So I think that even after many years, the challenge that we have is, one, we cannot really predict or understand what power we should be using for certain pathologies and in certain parts of the brain. And we only can use the initial ablation as a guideline for what moves we should be making next when the ablation doesn't proceed in the way that we want it to. Either it be, usually it being not enough power or not enough ablation. So I think that, this question, again, this question of can we put a laser in, over the years now needs to shift to should we do it? And again, this patient ultimately got a craniotomy and did fine. This patient's not, is symptomatic from the cyst and probably should have not been offered the procedure. So, but does that mean that all cystic tumor or no cystic tumors can be ablated? And I'm going to get to that in a moment. But here's another important Cornell study, okay, that if you want dessert or craving it, you probably should ask for, a waiter or waitress that's overweight. It's funded by Cornell, very important for dessert lovers, that you're much more likely to order dessert if your waiter or waitress is overweight. So glad to see that was funded. All right. So here's another cystic tumor, okay? Now this is infield recurrence after radiosurgery. Now, cyst fluid tends to be an insulator. So if you just stick the laser in here, you'll just, heat up the fluid a little bit, but it won't accomplish the task. So this, how to approach this. Now, there's no question, if you look at this like, well, can you take this out? That's not the question. Many of these can be taken out. This is not an argument against craniotomy. So if you choose to do a craniotomy, certainly it's a standard approach. It's straightforward, and you deal with it in a very straightforward fashion. But if you want to use laser therapy for something like this, how this is done is very similar to how we radiate or perform radiosurgery for large cystic, mets. You put a biopsy needle here, you pull the cystic fluid out, you put the laser in along the long axis, and then you perform the ablation. These patients can do fine. So I think having cyst fluid in there is not necessarily a contraindication, but again, it's got to be the right patient, right kind of tumor, right scenario. If you just leave the cyst fluid in there, it will not work. But you have to, if you have to pull the fluid out, you can do it in the same sitting if you choose to do so. Now, this is a patient with recurrent glioblastoma. And I think when you look from an anatomy perspective, this patient's already had, one or two craniotomies, and this question of can we do it from a morphology perspective, from a target perspective, this can absolutely be done. So what are the variables that are important? I think for anybody who deals with recurrent gliomas, this is a challenging field. I think that we don't have a lot of black and white rules. We have to look at the patient. We have to look at other variables. There are factors that are important in the same way that we choose to do a repeat craniotomy or any other procedure that we decide to take this patient through. If this patient's neurologically intact, we potentially are going to make different decisions from if this patient's Karnofsky is 50. And I think when we started as a field, we felt that this procedure was right or better for these patients who are more neurologically impacted, right? So if you have a patient who's a KPS 50, has this recurrence, well, probably not going to tolerate an open craniotomy. We should, laser therapy is less invasive, it's minimally invasive, maybe it's better. But I think that the same criteria that we use for craniotomy is actually not that different for laser therapy. You have to bring these patients in, they have to undergo general anesthesia, and you're still taking them through this procedure that we know is ultimately just going to be palliative. Now, can you use laser therapy in recurrent high-grade glioma in a way that's meaningful? That is not new information. That's information that's been published multiple times, that you can get meaningful palliation in the right clinical setting in the same way that we use other tools in order to do this. And this has been, although published for, over the course of the last 20 years, we still see these publications coming out. And I think that there are some real challenges with answering this question. I'm going to get to this at the very end because, the real question is the intervention that we take really beat the natural history of the disease? And we have so many variables in high-grade gliomas that become important factors in how these patients do. But there are some things that we have learned in terms of creating some real boundaries for when this should be used and shouldn't be used. So here's a case, 80-year-old, mild headaches, large mass. Volume is sitting somewhere around 60 cc's. So again, remember that 10 years ago, we were seeing publications that you can do this fairly easily with 20, 30, 40 cc tumors. So this seemed a little bit crazy, but it was just pushing that boundary in a setting where we actually still didn't have a lot of data. So maybe we could get larger ablations if we increase laser exposure time or use more lasers. So pushing the boundaries of the technology when we didn't have the data to guide us. So this patient, has multiple lasers put in, and I'm going to go through some of the, factors here and the early things that went wrong that allowed us to do this, better 10 years later. So what you see here is laser-induced cerebral edema, okay, from a very large mass getting ablated. This patient ultimately had to have a craniectomy and then passed away from this, from refractory cerebral edema from the laser exposure. So this is a terrible outcome. And I think 10 years later, nobody would even try to do this. This is, I think we've learned that the target was too big, the laser exposure is too long, and again, probably not the right patient, okay, for those reasons. So I want to go back to the target is too big, because over the last 10 years, this boundary continues to get pushed. So why can't you ablate large targets? It's because of the edema that occurs after the ablation, and this is true for both systems. So then you see, came out from the Cleveland Clinic group, said, well, why don't we ablate this and then pull it out via a minimally invasive approach? And so this is their first 10 cases that looks at using laser therapy plus BrainPath in order to deal with these tumors. And what we see here is that in these large callosal tumors, they can be ablated, but the morbidity that occurs for these patients all occurs in the larger tumors. So as even in this scenario, the tumors greater than 10 cc's uniformly do poorly. And so I think what we want to see, and even with the LITT+Brainpath, you remove the mass effect out of the equation, the overall survival in that series is about 15 months. And again, we come back to the same question, that are you really beating the natural history of the disease when you're taking patients to this approach? And we do know that if you ablate more tumor, these patients will get better. But again, as is the case with, neurosurgery, we're seeing that this publication looks at this idea that if you ablate more tumor, you will get better survival in these glioma patients. And again, this is the same exact curve we saw from the German group in the late 1990s, saying that if you ablate more tumor, you will do better with these patients. So that we, in some sense, are still answering some of the same questions, and we're left with the same questions even 10 years later. In the world of gliomas, now we're asking that if we can achieve some type of meaningful survival benefit with a low morbidity procedure, does it make sense to offer it to everybody? And it's a challenging question to answer. So in 2009, we had this question that what's the right size for ablation? And I'd say 10 years later, we're still asking some of the same questions. Is what is the right size for ablation? Is there a way to get patients through it? Now, for some people at Cornell who feel like they need another degree, especially when we're in quarantine, this happens to be a great way to get another education. One of the only universities in the country in which you can major in wine. So if any of you guys are looking for another degree, I think this is probably a good one to get. All right, let's go back to this. Okay, so looking at this large tumor, okay, I'm going to concentrate now on this idea that we didn't actually understand the impact of laser exposure. So look at these exposure times, 24 minutes, 34 minutes, 18 minutes, because at that time, there's not the idea was that maybe if you expose the tissue to longer ablation times or a longer period of time to heat, that you can then create larger ablations. But since then, we've gotten a better understanding of ablation dynamics and an understanding that all ablations follow this curve, and regardless of the pathology. Now, this is for the Visualase system. The NeuroBlade system is a pulsed technology. The exposure times are different, but when you look at continuous exposure to heat, no matter what pathology you are ablating, you're probably maxing it out at about 3.5 to 4 minutes, no matter what you're ablating. So your better technique now is to stop at 3.5 minutes or 4 minutes, let the brain cool down, and change some variable in your procedure in order to achieve this, achieve the ablation that you're looking for. Okay. Now, and again, in 2009, we're asking what power do we use, and we're still asking the same questions 10 years later, but they've gotten more sophisticated. What's the effect of gadolinium before and after the procedure? Can we predict power and durations? What do we do with subsequent burns? And how do we do better in this procedure than saying, well, this is my anecdotal experience, or these are the judgment that I can make, because we've done, a bunch of cases. This is true, I think, for all users. So, we had these, questions, what's the right patient and what's the appropriate pathologies? And I think we've moved the needle maybe a little bit, to the right. So when we look at in neuro-oncology and where laser therapy fit in 2010, we've moved something. So in recurrent GBM, it was an absolute yes. And now 10 years later, I'd say we've rewound a little bit and said, well, maybe. I think we're understanding the factors better. Upfront inoperable glioma, it was a maybe. I think every center that has a laser program, I think we're going to get about the best data that we're going to get. I think for people that, those would say, well, I'm not going to do this until we see class 1 evidence. I think that's just never going to happen. And, there's just a lot of reasons for that. And these other things here, low-grade gliomas, it's a maybe. Infield recurrence after SRS, I'm going to talk about, in a few minutes. I think this is one of the home runs for the technology. Recurrent low-grade gliomas, maybe. So do we change the overall or, progression-free survival for these diseases? I think for inoperable high-grade gliomas, the answer is yes, because laser therapy offers us an ability to cytoreduce in addition to the other tools that we have. Everything else is still a question mark, I think, 10 years later. Now, I think I have about 5 or 10 minutes here. I want to talk a little bit about recurrent brain metastasis or radiation necrosis. I think this is a real home run for this technology. And I think this technology has the ability to change the way that we look at this disease. So here you see this arrow at a small post-radiated metastasis. You see, you do a surveillance scan, patient's asymptomatic, you see it looks a little bit bigger. And then we get caught up in this, well, what exactly is it? Is it radiation effect? Is it radiation necrosis? We do advanced imaging, we're not sure. We watch it, it gets a little bit bigger, you see edema. This is sort of probably sitting right in the middle of the arc of fasciculus. Like now the patient has headaches, some mild aphasia, you do a needle biopsy, you see some tumor cells, you see some necrosis, and now what? You say, well, we'll just put the patient on steroids because our belief is that if this is radiation effect or radiation vasculitis necrosis, that it'll plateau, it potentially grows, and then you have lost the ability to intervene. So this is a very common clinical scenario, and I think one that's becoming much more common, that, you know, as we use whole brain less, and as we use stereotactic radiosurgery in more scenarios, we find that, and these patients are living longer, that the idea of infill recurrence is a function of the length of time that you follow these and the size of the tumor in which you're radiating. And that number for recurrence can be different depending on the technique, the series that you look at. It can actually be strikingly high. Now, we do try and have tried for many, many years to differentiate between radiation vasculitis and necrosis and recurrent tumor. We have non-invasive ways to do it, and any of the ways that we look at doing it have, for a specific patient, is potentially never exact. And all of the non-invasive tools that we have to do this, that, you know, for any given patient, is not a variable sensitivity and specificity. And then we have all sorts of other challenges. And look, laser therapy is not the answer for everything. If we look at the use of Avastin for radiation vasculitis, this is a meta-analysis looking at the conclusion you draw from this is that some patients will respond to Avastin for a period of time. And all of us have stories where we'll give 2 or 3 doses of Avastin, these patients do great forever. But we also have stories where we'll give Avastin, we have to continue it long term, and when we stop it, these things just come raging back. So how can the introduction of this technology change the way that we think about this disease process? So let's look at this. You know, here's a tumor, there's some T1, T2 mismatch. We suspect that this non-invasively, that this is radiation effect. We do another scan 6 to 8 weeks later. It continues to grow. You see a high choline peak, but the FET-PET TBR is low. Is this radiation necrosis? Not sure. We start Avastin. Despite that, it continues to grow or to progress. And so the lesion, this infield recurrence, continues to progress, and this is surgically inaccessible. And I think we turn to what is our gold standard. Say, let's do a needle biopsy. And the challenge, I think, with needle biopsy is sometimes the pathology is clear, but in whatever little data that we have here, almost 35% of the time, it's a mixed picture. And I'm going to get into it if I have a few moments here into why this is even a problem for us as neurosurgeons who deal with this problem. So I think we're not asking the right question. I'd say because we don't actually have a gold standard that is right all the time, we should be moving to making this a purely radiographic entity. These things are progressive, they're enhancing, they're inflammatory, and they're a reaction after radiosurgery. And potentially, even the needle biopsy for a particular patient does not help us make the decision on how to treat it. Sometimes it does, but there's at least a third of patients for which it doesn't. So in my mind, the right question is it progressive? And that's really the only question we have to ask. So then we went back and said, well, if a post-SRS treated metastasis demonstrates progression, how do we know if this is going to stabilize or progress? And is it possible that if we identify progression early, that we can better define the time for intervention? So really this comes down to this. And when you see something like this and you see it progress, what's the chance that it's just going to go away on its own or progress? And so at every time point, which is, you know, at most institutions, a 6 to 8 to 10 week scan, you have one of two options. Either it plateaus after whatever you do, or nothing, or observation, or it continues to progress. And what you see here in this large study of about 500 surveillance infield recurrences is that after your first scan, your chance of progression is about 50%. And after that, it's much more likely that it's going to progress rather than plateau. And once you get to 3 or 4 scans out, your chance of progression gets into that 90% range. So really, I think that when we get back to this and we get back to watching it and waiting or giving steroids and observation, I think that the questions we're asking, well, is it radiation? And it's not just us. It's the radiation oncologists, it's the medical oncologists, the radiologists. It's everybody who's dealing with this disease. You know, and our first step is to ask, what is it? And while we're asking what is it, these things have a tendency to progress as we're trying to get that answer. And as they progress, we potentially lose that time to intervene. And if we have a treatment that potentially treats both, the question is, does it even matter? Okay, and that's what I'm going to get. So here we see, you know, a couple of the studies that have been out, mostly in the last 5 or 6 years, mostly without biopsy, showing control rates in the 80% range for dealing with infield recurrence after radiosurgery. And I'm going to talk about this one, you know, the Beecher study from Houston, and why why I think that their progression-free survival is lower. And I'll get to that in a few slides. So after this, after 10 years of multiple centers looking at this, we do have somewhat of a guideline. Okay, there is an algorithm here to look at these things, to ask the right questions, and then potentially to intervene. This is certainly not a steadfast rule, but it's meant to act as a guideline for how we can make these decisions. Okay, now, I think one more tidbit about Cornell. So National Chicken Nugget Day. All right, I'm not sure if you guys realize this. November 13th is National Chicken Nugget Day. Why is this so important to people at Cornell? It's because the chicken nugget was created at Cornell University. Okay, Professor Robert Baker, and interestingly enough, even the folks at Cornell continue to argue whether the creator of a chicken nugget was a hero or a villain. So I think where you sit on the health buff side will help you decide. But this is one of Cornell's greatest contributions, I think. All right, so going back to this, that understanding infield recurrence and how we define it as a group. So how do we identify progressive enhancement? How does access to LITT change our decision-making? Okay, is the question we were trying to answer. So we did a survey, and these are surveys of people, of neurosurgeons who define themselves as neurosurgical oncologists. That's wanted as much of a group that was similar. Okay, so this all comes from the CNS tumor section group, and we found that in that scenario, more than half felt that any growth over 2 scans, 6 weeks apart, defined progressive enhancement. But that was certainly not everybody's opinion. Everybody within our group of neurosurgeons, we are divided in terms of how we define progressive enhancement, or when we decide something's progressive. Now, the other thing that we are divided on is how we define radiation necrosis versus recurrent tumor. For some of us, it's any tumor cell on the slide makes it a recurrent tumor. But for others, you have to have greater than 50% tumor cells or recurrent cells in order to find it. So here is our baseline issue, that if we can't come together on how we're defining the disease entity, we can't move the needle to the right. We have to, as a field, have to come together in how we're defining what we're treating, which is where and I'm going to get to, this is where we're stuck, okay? So, what we just sort of learn now, access to LITT changed the way that you manage this, okay? So if you have access to LITT, more than half are going to manage it that way, when they're surgically inaccessible. But if you don't have LITT and you don't have other options, you're going to use medical therapy, like steroids and Avastin, which makes a lot of sense. So if you don't have the technology, you're not going to get used to using it. Rupa, I think, am I out of time, Rupa? I think you're on.
No, you're fine. Keep going.
Okay, fine. So I think access to technology changes the way you approach the disease. But even before we get to access to technology, if we as a group cannot come together on how we define the disease we're treating, we're never going to move the needle to the right. So this was, a small study. And imagine if we expanded it to, the broader neurosurgical group, we might find that the disparities get even wider. But as we all know, survey studies are very difficult. But I think what we learned from, just even from neurosurgical oncologists was that even using the needle biopsy to distinguish the two is very challenging from center to center and from user to user. So what is the right time to treat this? I think we still have some of those questions, but here are some of the important factors that from the studies that are published, we've learned that, so we say, okay, well, progression on 2 scans, it's got to get to a certain size and you have to see a certain amount of growth on each scan. So there are, for those who are listening, who, watch these things plateau a lot. Remember that study is done with these definitions in mind. So if you see something that's, 4 millimeters on a scan, and then on the next scan it's 5 millimeters, that doesn't count as progression, right? It has to grow a certain amount for it to even hit the check mark of radiographic progression. So what's the right time? We have some guidelines, but here's what we know. We know that if you wait till the patients are on moderate or high dose steroids, which is in my mind, one of the major goals, what we want to do is avoid long-term steroids for these patients. You have to intervene early. If you wait till there's mass effect, if you wait till they're on moderate dose steroids, most of those patients will then never come off. But if you intervene when they're on low dose steroids or not on steroids, but you're convinced it's progressive, those patients are going to successfully stay off steroids for the remainder of the time period that you get control. And what else we know? Across the spectrum of neuro-oncology, whether you're dealing with high-grade gliomas, recurrent high-grade gliomas, infield recurrence, your response rate is going to be dependent to the size. Where if you think about 10 years ago, when we saw our first publication, we saw large ablations being done. It can be done. But I think we've moved the needle of asking, should it be done? Because every series that we see that that the larger tumors that you approach, you're going to decrease your control rate and you're going to increase your morbidity rate. Okay, so what I've proposed is that whereas we often take this path for these patients, where we see some growth, we do advanced imaging, we do needle biopsy. If it's successful, we consider surgery. Repeat SRS is certainly an option. There are other options. If it's radiation effect, observe versus Avastin, and by the time we made all these decisions, we are 16, 24, 36 weeks out. And I'm proposing to the field is to simplify this. Because we've made infield recurrence into a neurosurgical disease, but we have to take control over the surveillance of these patients. That instead of doing advanced imaging, let's just, if we look and define progressive growth radiographically and eliminate all of, so of course, if we, I'm not opposed to needle biopsy, then why we have moved away from it, there's just not enough time to talk about it. But I think if we just move to defining this radiographically and then intervening when we think it's appropriate, I think there's a host of patients that we're going to help. So I think standard imaging can't consistently distinguish for a particular patient. The gold standard, the biopsy, is not always give us a black or white answer. I think we as a group need to agree on how we're going to define these. I think the word lesion, which we commonly use, is extremely vague. I think we need to do better than that. And then there are, other issues with the needle biopsy, which I didn't get to here. So, 10 years ago, we had a lot of baseline questions. The questions have matured here. We're still asking questions that relate to image registration, insertion methods, ablation power. We're still trying to figure out who the right patient is and what the right disease is. We have this opportunity to create, big data, and we've not taken advantage of it in laser therapy. We're still seeing, we're starting to see multi-institution retrospective data and some prospective data come out. I think NeuroBlate Registry has done a good job in terms of giving us, bigger data. But I think what we yearn for in the field is, you know, a more is something better. And I think in the world of epilepsy, the field has really come together and said, we want a trial for medial temporal lobe epilepsy. It was pushed by the scientific community, the industry engaged, the FDA engaged, and we are half enrolled in, you know, in the national SLATE study, which is a study across 19 sites. Now, this is not going to probably change the culture of the field. In the world of epilepsy, I'm not sure it's going to matter what the trial shows. This will get the FDA indication, but the culture has already moved forward, deciding that this approach makes sense for medial temporal lobe epilepsy. And so I think the trial endpoints are very reasonable, and I think we're going to meet them. Now, we are stuck in the world of neuro-oncology. We have not been able to figure out what we want as a group to move this needle to the right. And I think that, is that a trial in glioma? Is it a trial in recurrent glioma? Is it a trial in infield recurrence? Is it a trial at all? Are we going to try to create level 1 evidence? These are some broad questions, not only nationally, but now internationally, that we have not come together on in the world of neuro-oncology. So until we do, we are not really going to move this needle in the direction that we wanted to in the world of neuro-oncology. Now, in these last 2 minutes, I'm going to just change topics here, because I think, you know, when you're at Cornell Medical Center in New York, I understand that you understand, you know, that this is, you know, you understand Manhattan, but I want to remind everybody who's from New York that there is this state right next to New York called New Jersey, okay? And actually, from a landmass perspective, is actually quite large, okay? So for those of you guys who don't know that New Jersey is right next door, here we are. Here's a map. Rutgers Cancer Center is landlocked, just like many other institutions. This is what it looks like. So the only way for us to go is up, and every now and then when the place can buy a block, we can expand. This place has almost doubled in size in the last 20 years. Now, there are a lot of things that Rutgers is famous for. Most recently, Rutgers is now become in headline because of the saliva test for COVID. But long before the COVID saliva test, this is what made us famous, okay? The food truck was invented at Rutgers. I encourage all of you to come down and try a sandwich out of a food truck. These are called the grease trucks. This is the most famous landmark on and I will tell you that, you know, the food trucks have gone through a lot of history. And when I was in college, we saw the grease trucks shut down. The entire Rutgers community of students, which is 20,000 plus students, protested on campus until the Department of Health would allow us to eat meat out of a sandwich, eat meat out of a truck. And so when we used to run the courses at Rutgers, we got everybody into a Rutgers cultural experience. We'd take everybody to Are You Hungry? We'd make them eat a Fat Cat sandwich right before they got on a plane, which was not a great idea, but it is a cultural experience that you couldn't miss. Now, for those of you guys who don't know what a Fat Cat is, the Fat Darryl won the Food Network Sandwich of the Year for 4 years in a row. And if you don't know what a Fat Darryl is, and we know how the Cornell engineers love building things, and so here you go for the engineers. Here's your schematic. Okay, it's a hoagie bun, marinara sauce, chicken fingers, mozzarella sticks, French fries, and for all the health buffs, it adds lettuce and tomato. So if you're ever in the mood to build a Fat Cat, this is how you do it. Now, this is Scott's parabola for new technology. I think in 2010, or 2009, this is where laser therapy sat. We saw some encouraging reports. And 10 years later, I think we are higher up along the curve. I think that there's been, there's a lot of enthusiasm for it. I think users of the technology have really started figuring out where to put it in their clinical algorithm. But I think before we get to this potentially dangerous term, which is standard treatment, we have a lot of work to do. So I want to thank everybody for your attention this morning. And thank you very much for the opportunity to speak.
Thank you so much. That was really a fantastic overview and introduction to a lot of the people here. I have one comment and then a couple questions if you have a minute.
Yeah.
First of all, completely agree that the lack of gold standard that we have for diagnosing radiation necrosis is a major systemic problem. And I think a lot of us are trying to address that. But one of the beauties of LITT has been that it regardless of which the pathology is, it can be an effective treatment. So I think for us, that's been something we've been trying to, teach our neuro-oncologists and radiation oncologists. One question I had was how you got your neuro-oncologists and your team to sort of buy into it. I think one of the struggles that we have is, given, like you said, the lack of evidence that we have, lack of quality evidence that we have to support LITT from a basic science perspective and from a really randomized trial perspective. How have you been able to convince your team that this is safe and effective and really can be used, both upfront and for recurrence?
So I think that the challenge is different than they were, say, 8 or 9 years ago. Look, 8 or 9 years ago, there's a lot less around, there's a lot less published, and looking at 3, 4, 5 centers around the country. I think now you're looking at 110 or 130 centers around the country, so this thing is much more in widespread use. And what I tell centers, young surgeons or young groups who are starting out is that you want to start with the ones in which there are no good arguments for. Start with the ones that are surgically inaccessible, the ones where you can't really operate on them, the ones where, they have a little bit of edema, they've already gone through 1 or 2 cycles of growth, and you don't have good options, and a patient who's clinically doing very well. So you find those, and they are tough to find. It gets a little bit frustrating to get off the ground, but when you start that way, and you have early successes, I think that you can then catapult the program. And again, I think that the field is different now than it was 9 or 10 years ago, even from that perspective.
Ted, I think, did you have a question?
Yeah, definitely. Can you hear me? Because I'm sort of in the middle of the hospital somewhere with sketchy. Yep. So Shabbar, first of all, thank you so much for that wonderful talk. I really enjoyed it. And one of the things that I loved the most was really your honesty with the cases that you tried to apply LITT to and found that, the indications may have been questionable and the results were not optimal. And I think, that's what a very valuable bit of information that people need to hear in terms of understanding this technology and having a better sense of where it can be used and should be used. And I think you very rightfully point out that just because you can do something relatively safely doesn't mean you should do it, particularly when there are other alternative treatments that we have. But there are a couple of things I don't quite understand. We started doing LITT here about 5, 6 years ago. We used the Visualase, we switched to the Monteris, and we use it for epilepsy and neuro-oncology, but honestly, we only use it for a very limited number of cases and a very limited number of indications. And the cases and the data you show in the beginning show a lot of the limitations of it. And then you showed a slide at one point that said, like, these are the possible indications. And you went from 2009 to, well, maybe we could do this, maybe, to 2020 saying, yes, 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 we should be doing all these other indications. But the data that you showed doesn't necessarily support that because we still don't have good efficacy results for a lot of those histologies that you presented. And as you rightly point out, there were a lot of issues treating a lot of those histologies, particularly larger sizes. So I wasn't sure how you had made that leap from maybe we should be doing this to yes, we should be doing it based on the available data in the literature. So that was sort of my first question. And I totally agree with you that where you ended is really the best sweet spot for LITT in neuro-oncology is, of course, recurrent Mets after stereotactic radiosurgery, and that usually there's a combination of mixed pathology, and LITT can be very effective in that area. But I still think that the indications where I feel that LITT offers a better result than I can give a patient with a craniotomy is still very limited. And I think that's somewhere where we've been held up in terms of that. Yeah, we could do it, but should we do it based on something else that we have to offer that we think has better evidence and as good safety regarding outcomes? So those are my thoughts.
So let me try to address both those things. So one is, Dr. Schwartz, I think you're 100% right. And I say that even though I was an early adopter in laser therapy, I think that I myself, over the years, because of the things, become much more conservative, meaning that I do a lot less glioma work with laser therapy than I did 10 years ago. And you know, you talk about that, you know, the slide. I'd say that, you know, there's a lot more people now writing about this and publishing this, you know, and there are people who, you know, so for example, the St. Louis group, you know, Gene Barnett's group in Cleveland Clinic, you know, have really pushed this in the world of gliomas. Now, one of the questions, and we can really get into this, is what level of data and evidence are we going to need in order to push the needle in one direction or the other? Now, the world of gliomas and recurrent gliomas is extremely challenging. There's a lot of variables involved in it, and I think that for anybody who is looking to do, for example, a trial in using laser therapy in gliomas, I don't think it's ever actually going to happen. It's very hard for us to engage in a focal therapy for a diffuse disease in which the answer is probably not surgery. You know, it's going to be something else. And so I do look, so, you know, rewinding back to that question. So corpus callosal glioma that's less than 8 cc's in a patient who presents who say carnoscopy 80 or 90. Now, if you do a needle biopsy and take that patient under Stieg protocol, we know what the outcome is going to be. And we do have class 2B data that if you know, perform laser therapy and achieve side reduction, that you will potentially move that needle to the right in the same way that if you take out a frontal lobe tumor before radiating it and, you know, applying chemotherapy to it. Now, those are not obviously, you know, the only factors involved. But when you take something that is surgically inaccessible and you cytoreduce it with laser therapy, you're not curing the disease. We're never curing this disease. But can you improve control over just doing a needle biopsy through protocol? The answer to that is probably yes. Now, if as a group or as a patient, that's not good enough, that's a very patient-to-patient or institutional kind of decision. I agree with you. I think there are 2 home runs in this with this technology. That's infield recurrence for radiosurgery, after radiosurgery, and it's lesional epilepsy. Those are your 2. Everything else, I think, is going to be a gray zone for, you know, the foreseeable future until we figure out as a group where we want to move that needle. So everything you're saying, I agree with you. I'm not sure that I, you know, was able to mature the conversation just in the length of time that we had here to talk.
Yeah, just one quick follow-up. You know, even with lesional epilepsy, when you have a right-sided, right MTS, the seizure control rates with LITT are still not less efficacious than open surgery. So although it's definitely in the algorithm, and it may offer advantages on the left side for memory outcome, it's unclear which are the patients on the right side where it should be done. If you're going to get a better tick in a way. I mean, it definitely works, but you know who you offer the procedure to.
You know, I didn't really, you know, we didn't really talk about epilepsy. So I think you're right. I think that even in the world of lesional epilepsy, there are some, you know, challenges, and there's still some discussions that are in. You're absolutely right. There are going to be scenarios in which the open, you know, temporal lobectomy, and we know as surgeons that open temporal lobectomy is very effective, and especially on the right side, you can get a patient through it, and the side effect or morbidity profile is very different. You know, you look at the data that's coming out with lasers, and you see cranial neuropathies, you know, with lasers that are placed immediately, and you just never see that in an open operation. And the challenge is that the culture of the patient is also, you know, potentially for some centers, you know, dictate the approach that you take. You know, there are patients who will never agree to an open craniotomy, never. You know, some of these seizure patients will say, I'm just not willing to undergo an open procedure, but you offer them laser therapy, which is a 2 millimeter port, which is something that is, in a lot of senses, less invasive than intracranial EEG. And these patients say, okay, well, I'll give that a shot. And if you're able to, you know, if you have a, you know, 60% chance of making them seizure free, that's actually not that bad. So I look, you know, I think anybody who's been doing epilepsy surgery, I think, you know, as you rightfully point out, there are the challenges in that field for sure. In terms of our desire to achieve seizure freedom in our first intervention, and then, combating all the, other issues that exist specifically in the field of epilepsy. But I think the things you're pointing out are absolutely correct. And I think the field is, still, even after it gets the indication, assuming it meets the endpoints from this trial, is still going to continue to have that conversation.
Great. Thank you so much. Really enjoyed it.
Great, thank you. And I pretty much out of time. One last question that someone had asked that they requested that we pass along is a question about how you deal with cysts. You kind of mentioned how you moderate the thermal diffusion within a cyst, but do you typically decompress that cyst prior to ablating? Do you feel like you have better outcomes that way? What's your limit?
You have to take the cyst out. If you just put a laser into a cyst, it's just not going to work. And I think those are very, unique and rare situations. I'd say that, from what I talked about, in this talk, there are things that, I have myself, while I've either tried it or seen it tried, I've said, I don't even offer the procedure, too. But there are some situations in which if you feel like it's the right approach, then, this is one way in which you can do it.
Great, thank you. It was really a pleasure to have you. Thank you to everyone for joining.
Thank you guys so much. Hopefully this was educational. And hopefully I actually taught some things about Cornell.
Yes, I learned many things about Cornell. All right, take care, everyone. This lecture will be available online, and we'll be sending that out.
Everybody go get some chicken nuggets. All right.